actually, this is great to have Morty Searle come in and talk about a very different approach for how to get patients early, maybe even before they test. It's when they might actually are reaching out to high-risk patients. So Morty, if you could talk a little bit about the COVID Plasma Initiative and how you have engaged and how you've been expanding.
Sure, Martha. Thank you for having me. It's an honor to be on this panel, an honor to be part of this webinar representing COVID Plasma Initiative. So let me give a little bit of an introduction about COVID Plasma Initiative. Some of you may be wondering, what is COVID Plasma Initiative doing on a monoclonal webinar? Did I get the wrong invitation? I'll give it a little bit of a 30-second background. We were formed in March 2020. Myself and Chaim Lebovitz, the co-founders. It's a grassroots, totally volunteer-based, we're not a healthcare provider organization based in the Jewish Orthodox community. We formed under partnership and guidance from Mount Sinai Medical Centers in New York City. Dr. Bander, Dr. Shatkus, Dr. Aberg, and Dr. Reich have given us tremendous support all throughout and guidance. So we were tasked with initially collecting plasma. Our communities had been hit early in March, and we had therefore the first recovered patients. They reached out to us and we started recruiting donors, and then it just went from there to doing anything to further the plasma treatment. Talking to blood centers, working on procedures, setting up conference calls between EAP data and local hospitals. And it rolled out nationally, that the organization, the effort, and to where it is today, where the majority of COVID patients in America who are admitted to the hospital receive plasma. One thing we learned throughout that whole journey, which we've leveraged, besides for all the relationships and tools and credibility, is that treat early, treat wisely. That the key to successful plasma treatment we were seeing in patients we were sending in was that we needed to have early treatment of plasma. Preferably at that point, the emergency use authorization, and as of now for plasma, is only upon hospitalization, but it should be immediate, not within the first couple of hours, and wisely with high titer plasma. And because of that, we started tracking and had our eye on the Regeneron and Eli Lilly monoclonal antibody product. Why? Because that was a perfect extension and amplification of treat early, treat wisely. It was aimed at the outpatient population and it was sort of this is a metaphor as a sniper rifle, the powerfulness of the monoclonal compared to plasma. So treat early, treat wisely. We were tracking it. We were sending patients in to the Regeneron randomized control trials that Mount Sinai was running, and we were very, very impressed with the results that were happening. So as soon as the emergency use authorization was issued for the Eli Lilly product in the beginning of November, and subsequently the Regeneron product, we made an internal policy decision in COVID Plasma Initiative to sort of focus as much efforts as we can on furthering this treatment in the community. And we formed what we call our MAB squad, MAB, monoclonal antibody squad, and we put together a core group of volunteers, and we focused on our goal. Our ideal for the treatment model was that somebody would wake up in the morning, they're symptomatic, they have a symptom of COVID, they would run to get a test. If that test is positive, a rapid or PCR, whenever it comes back, go in to a treatment site, and by the time they go to sleep that night, they know that they took care of getting their monoclonal treatment, and they lowered their risk of hospitalization and death to below 99% and even better for death. Now, in order to be able to do that, we determined that we needed to have 3 steps involved, and this was the model that we set up, and we set this up with the intent that it could be brought to other communities as well. And the goal again is to get from first symptom to treatment within 24 at the outlier for 48 hours from first symptom to treatment. And we did that by, number 1, we needed to get the word out to the community. We needed to spread the word. Why? Because people have to know about this before they're sick. People have to know about the monoclonal antibody treatment. They have to know its effectiveness. They have to know its availability before they have a symptom. Why? Because like I said, when they wake up in the morning and they know they may have been exposed and they have a symptom of COVID, they have to know, they have to know I have to go right away for a test, not say, you know what, let me see what happens, let me wait, because we know monoclonals work. Treat early. You got to treat it early. So we put out a huge education campaign. I'll speak about the specifics, but let me get to the other two steps to our model. The second step is that we as an organization had to accumulate and compile information on where the community could get treatments, where the treatment was available, what specific details a person needed to know as to expectations. For example, what qualifications did a site need? Was it a PCR, a rapid? The EUA allowed for 10 days from symptoms. Some places were more stringent. And what was the definitions? You know, what's considered immunocompromised to a specific site? So we accumulated, compiled, reached out to infusion centers and compiled all that information. The third step, it was to get that information to people who are seeking treatment. Make sure that the people who now know about monoclonals, who tested positive, who want to get their treatment, can be able to get this information, set their expectations correctly in order to get the treatment. And we found that if people have clear instructions, clear expectations, know exactly what's going to happen, that will get you very good saturation and very low drop-off rate from people seeking treatment to actually getting it. So let me go a little bit further into those three steps. Getting the word out. Getting the word out was the first one, hospital outreach or infusion center outreach, and then be able to connect the patients to the information. So in terms of getting the word out, what we did was we set up webinars in the community with Mount Sinai. We reached out to doctors. We set our website to doctors to spread the word, primarily community physicians, primary care, and we asked them to please get out the word. The Blaze 2 trial was very persuasive at that time. We asked community leaders, rabbis, other community leaders to tell their constituents, tell their congregants about this information. We launched a very large advertising campaign in community publications, internet, social media. We made ambassadors to please reach out to the community, and we put up billboards throughout our areas. And maybe perhaps the most powerful method was, as data was coming in as to the results, the first couple of weeks, as we were sending people, high-risk people that qualified for the treatments, and they were coming back, and we saw our hospitalization rate decline to the extent that now today, really almost all patients that are getting to the hospital are people who didn't qualify for antibody treatment, who weren't able to access monoclonal antibodies, which means that our knowledge saturation in the community is incredibly high, and people know about it, people are seeking it, people are getting it, and when they get it, it's effective for keeping them out of the hospital. And as that data got out, it just grew and snowballed and snowballed and snowballed, and more people knew about it and requested it. The second step, accumulating specific information as to where people get the treatment. So we set up a hospital liaison, infusion site liaison. We set up a site locator on our website, which was very easy to access for the broader community. And finally, and I'll end with this, the third step, in order to connect patients to the information. So we set up probably the most powerful part of this was our hotline. We have a 24-hour, 7-day-a-week hotline where it's answered. People seeking treatment can call in, discuss their qualification, if they qualify, discuss where to go, which site works best for them. And I think so far we've handled over 1,000 calls directly on that hotline. And with that, I'll hand it back over to you, Martha. Thank you.
Thank you so much, Morty. So we have about 10 minutes that were for more follow-up. So actually, let me ask you one follow-up question, Morty. So I understand that the model has been very successful. Like you started off with the Orthodox Jewish community in New York City, but you have expanded to the outreach to the Hispanic community. not only in New York City, but outside. Can you talk briefly? Is it your organization that is doing it, or are you partnering with other organizations, grassroots or community organizations to do that?
Yes, our organization, COVID Plasma Initiative, primarily my co-founder Chaim Leibowitz, we've done outreach to some of our other communities that we've connected to through plasma, and primarily the one example of that is the Latino community in Southern Texas, and really what it is taking these 3 steps, leveraging the ability of a community organization to reach people before they're sick, to them to know about it, give them clear instructions on where to get treatment, and then keep putting out the word, include positive data as it comes in. And we're very proud. And that was part of our mandate from the beginning, was that whatever model we grow, make sure that it's sort of like a keystone type of model, that it's translatable into other communities.
Thank you so much, Marty. And for those of you who are listening in, if you look at the paper that we issued this morning, you'll see some examples of some of the creative ways in which this organization partnered with others, including, for example, engaging pro bono, a marketing firm in Texas, who then did a big campaign with TV spots and news stories. So